Hello, everyone. I'm back, and we're going to be continue our discussion and learn more about coding other diseases of the circulatory system. With ischemic heart disease, there's certain combination codes that include both the atherosclerotic heart disease with angina. Code category I-25 details the location of the coronary artery disease and whether it's a native vessel that you're born with, if it's coronary disease of a bypass graft, the type of angina, whether it's stable, unstable, whether there's a documented spasm, and others. Please review figure 12.1 for a diagram of the coronary arteries. And again, we have two different types of angina broadly. This is chest pain, unstable, angina, and angina pectoris. You may want to Google these terms. In fact, I think I will show you some resources on this right now. And this comes from the National Health Service of the United Kingdom, and you can see some of these things here. Gives you some good information about angina, signs, symptoms, diagnosis. And angina, as we talked about globally, is chest pain, right? And here's what is very, very important. Stable, meaning that this is stress or exercise induced, and once you stop exercising, the angina subsides. Unstable means that it's more unpredictable, right? And so this can continue even when you stop exercising. So if you're interested, I'll be posting this on Moodle, and you can take a look at it and review it. And again, we see that unstable, meaning crescendo. In other words, we get angina that happens at any time, rest and what have you. The recommendation is that if you have unstable angina, people should go immediately to the emergency room to rule out a myocardial infarction. Angina pectoris is the chest pain that's due to the ischemia. In other words, when there's some sort of stress, there is the chest pain. The code categories I-20 identifies the forms of angina pectoris, and then subcategory I-25.1 includes the combination codes for the angina with the atherosclerotic disease, the native coronary arteries. Subcategory I-25.7 is similar, but this has the combination codes for the angina with the atherosclerosis of a coronary artery bypass graft. So in these cases, you don't code the angina on top of that because it's already included in the combination code. And there's a causal relationship when a patient has atherosclerosis and angina, unless the documentation says otherwise. We use these combination codes when both conditions are present. And to assign the correct code, we need to know the location of the coronary arteriosclerosis in the heart and the type of angina. And as we mentioned, we got into the STEMI, non-STEMI, the I-21, I-22. Now we're going to come back and revisit this. And what a myocardial infarction, we saw those diagrams earlier. It's an interruption of blood flow to the heart muscle. And ultimately, if it causes enough heart muscle damage, the heart will release troponins and other cardiac enzymes, and the heart muscle, if it's damaged enough, it will stop beating and the patient will die. I-21 code describes the acute myocardial infarction with onset of 28 days. We took a look at that earlier. And we took a look also at the I-21A1 through I-21A9 for other types. We also discussed the type 2. Let's get into the weeds about some of these other ones, namely the I-22. I-22 is a subsequent STEMI or non-STEMI, right? So this is the second one. We only use the I-22 when the patient is being seen within 4 weeks of the first one. We never use an I-21 code for a subsequent MI other than the type 1 or unspecified. And this could either be the principal diagnosis or not. Sometimes a patient will have an MI, get the I-21A1 code, right? Be treated, maybe have a stent, what have you, go home, be home for a couple days and come back with this subsequent STEMI and be readmitted. In this case, the I-22 would be the principal diagnosis. And again, if you're using an I-21, whether it's the I-22, excuse me, you should be using it with an I-21. The I-22 will not stand by itself. It could be a principal diagnosis, if like I described in the earlier scenario, or it could follow the I-21. But either way, it is going to be used with the I-21 code. And again, only use the I-22 if it's going to be used within the 4 weeks. When it's 4 weeks and 1 day and we have another heart attack, it goes from the I-21 again. And again, talking about the sequencing, patient comes to the hospital with the first type 1 STEMI, develops a second STEMI while they're in the hospital, which happens more often than we would think. The principal diagnosis would be an I-21 code. The I-22 code would follow because they had that within the 4 weeks, within the 28 days of the initial one, right? And likewise, if a patient is discharged and then has to come back and be readmitted, which again happens from time to time, this case, what is the reason for admission after study? It would be the I-22. Why is it I-22? Because it's within 4 weeks of the initial I-21. We would still code the I-21 because it's still a condition that requires management. And if a subsequent myocardial infarction of one type occurs within 4 weeks of a different type, we would assign the appropriate code, right? And again, the big take home that you need to realize from this slide is we're only going to use that I-22 code if both the initial and the subsequent are type 1 or unspecified. And there's some code also, code first notes. Big take home here is the type 2 myocardial infarction. In other words, a heart attack due to demand ischemia. It goes to the I-21.A1. We would not assign the I-24.8 as other. If we have a type 2 AMI and the underlying cause is dependent on the circumstances of the admission, right? So we only assign those codes I-2101 through I-21.4 to type 1 AMIs. It sounds very daunting, but I think once you do a few of these, it'll make a lot more sense. How do we know somebody has an AMI? Well, we have a history and physical. A lot of times these patients have issues such as hypertension, obesity, what have you. They've been treated for this before. We do a physical exam. We do some tests such as an EKG. And then important thing to check is cardiac enzymes. These are the troponins or the CKMB. These should be commented on in the note. They're also a part of the record as well. And if we see treatment involving intravenous plasminogen activator, commonly referred to as TPA, that's how we know that an AMI is going on. Usually these are very well documented. Chronic ischemic heart disease is basically atherosclerotic heart disease. This is coronary artery disease that has gone on and hasn't culminated in some sort of a MI as of yet. And we could have sudden coronary insufficiency, angina, and then ultimately develop into an AMI. Atherosclerosis is basically the forming of the lesions on the inside of the arteries, as we saw in those earlier diagrams. And this, we always use the terms arteriosclerosis, atherosclerosis. Atherosclerosis is talking about the fatty lesions. Arteriosclerosis is globally any hardening of the arteries, including those due to atherosclerosis. Atherosclerosis is the main cause of ischemia, not only in the heart, but the brain. We can also have peripheral vascular disease, right? And other things that can result in addition to strokes and MIs, congestive heart failure, chest pain, and kidney failure. And most of us know what atherosclerosis is, the formation of these fatty lesions inside the artery, resulting in not only heart attacks and strokes, but also kidney disease, peripheral vascular disease, and other conditions. Atherosclerosis is the main cause of ischemia in the body, including the heart, the brain, the extremities, and can result in stroke, heart failure, angina, infarction, and kidney failure. There are different subcategories about atherosclerotic heart disease, and there are codes that can describe old myocardial infarctions, ischemic cardiomyopathy, chronic occlusion of the coronary artery, coronary atherosclerosis due to lipid-rich plaque, and others. There are definitely some notes you should pay attention to that follow under subcategory I-25.8. I know this is a lot of material, but we still have one more video lecture to discuss heart failure and other diseases of the circulatory system. We'll see you then.